Hi, everybody. Thanks for joining. This is the September 22 edition of the Wilderness Medicine Journal Club. This month's topic is allergy and anaphylaxis. We've got the WMS anaphylaxis guidelines to cover first, and we'll move forward with a research paper and then a couple case reports. I believe Sarah's going to be covering the WMS guidelines. I just need to allow share screen, and it should already be good to go.
And can you guys see my screen or hold on, it didn't give me the option of just sharing part of the screen. Are you seeing like the whole desktop?
We see PowerPoint, the app.
Yeah.
Yeah.
Okay. Hold on one second. Let me just see if it'll let me do this. Oh, advanced. That's how I normally do it. Portion of the screen. And there we go. How about that?
Yeah, we see the PowerPoint being presented. Yeah.
Okay. All right. So the WMS anaphylaxis guidelines, and out of habit, I put objectives into everything. We'll define the allergen, antigen, allergenic terms briefly, because I'm sure most of us know that. Explain how the evidence shows that widespread access to EpiPens has saved lives. Quantify some morbidity and mortality from it, and delineate the WMS guidelines. So anaphylaxis, it's not just bee stings, it can be to food, it can be to any environmental stimulus that they have created an immune reaction to. It's acute, potentially life-threatening response to an allergen. It can involve multiple organ systems. And actually I learned that there's hieroglyphs from 2640 BC depicting deaths after a wasp sting. 2 to 5% of the US population has experienced it. It's 0.1% of ED visits, up to 1% of hospital admissions, depending on the study you read. And in 2010 and 2014, the Wilderness Medical Society reviewed guidelines showing that even if it's a non-medical person, if they're a guide or they're responsible for first aid in wilderness group settings, they should be trained to administer an EpiPen. So expedition leaders, outdoor instructors, guides, park rangers, camp directors. It can have many manifestations. It can be a rash, it can be swelling, it can be difficulty breathing. And of course, this is not amenable to randomized controlled trials. We can't just see what happens when we do different things with anaphylaxis. We have to rely on experiential evidence and literature reviews for the best evidence. So quick touching on the terminology from the WMS guidelines. An allergen is the environmental substance that triggers an abnormal or heightened immune response. And an allergy is an abnormal or heightened immune response. Asthma is an abnormal bronchial constriction and inflammation that can arise from exposure to a trigger, whether that's an allergen infection, extremes of temperature, or physical exertion. An anaphylactoid reaction is an acute inflammatory or anaphylaxis-like reaction without necessarily having prior exposure to the inciting antigen. Angioedema is that subcutaneous or submucosal swelling and inflammation. And that can be actually from a medication reaction, an allergen, or a deficiency of an inflammatory inhibitor. And an antigen is the substance or agent that incites the immune response. A hypersensitivity reaction is the heightened immune response against the antigen. And that's basically anaphylaxis, that type 1 hypersensitivity reaction. And so for example, in other hypersensitivity reactions, what plant can incite a type 4 hypersensitivity reaction? And that's poison ivy. So overview of hypersensitivity. When we talk about anaphylaxis, we're really talking about that type 1 hypersensitivity reaction with the IgE antibodies that are released. So the first exposure to the antigen is usually not the anaphylaxis generating exposure. That's the sensitivity generating exposure. And the B cells then make IgE antibodies. So it's the next time that you get a bunch of bee stings or the next time that you eat peanuts that you have this reaction. So in the literature, 1.5 to 2% of the population's at risk. So if we have 326 million people in the US, that's 5 to 6 million people at risk. Annual deaths, depending on underreporting and extrapolation from regional data, it's anywhere from 200 to 1,500. In pediatrics, it's most often food, peanuts, milk, shellfish, tree nuts. In adults, it's often medications, radio contrast media, and in all people, pediatrics and adults, bee stings are the second leading cause of anaphylactic death. And so Knowles and Outward Bound did some pretty great data collection where they evaluated a period of time where they had, Knowles had about 5,000 students a year, give or take, median age of 20. And in that time, they had 21 students and 3 instructors have anaphylaxis field cases. 13 were from food, 8 from bee stings, and 5 were first-time events. Outward Bound had 40,000 students per year, median age of 16, and they ended up with 39 students and 7 instructors anaphylactic field cases, with 11 from food, 20 from bee stings, and 10 first-time events. And then here's a great table from the WMS guidelines comparing those side by side. And so it's not a huge number of people, but that's a large number of people. And so this goes in line with recommending that the guides are trained to administer EpiPens. And the increase in anaphylaxis and allergic reactions, which is very interesting to me, since 1984, we've had a 12-fold increase in anaphylaxis reactions on Knowles trips because they've been keeping pretty excellent data. So, why is that? Is that we're actually just getting more biologically sensitive, or I don't really have an easy answer to that. So anaphylaxis type 1 hypersensitivity, mostly IgE dependent. The B cells, like we discussed before, react to that first exposure. Second or later exposure is usually the anaphylaxis. The IgE antibodies will bind those mast cells, basophils, and cause them to release histamines, tryptase, proteases. Other cells can also be activated, and sometimes those are responsible for the later reactions, the coagulopathy that can happen after these severe anaphylaxis reactions. There are also IgE independent pathways, but those are less understood. And the clinical manifestations, you'll have a systemic reaction. Cutaneous mucosal signs are suddenly, they can progress within minutes to hours, sometimes accompanied by respiratory compromise, hypotension, persistent GI symptoms, or it can be more acute onset of hypotension or respiratory compromise, including a severe bronchospasm or laryngeal involvement. And this does not have to have skin involvement. And the fatalities are usually from the respiratory or the cardiovascular compromise. And so one patient in particular, she called 911 to advise the clinic she was on her way here, actually, when we were out in the Aleutian Islands. And I could hear her whistling as she tried to breathe. And so I literally met her at the door with the injections and did the EpiPen immediately and Benadryl and steroid immediately. So treatment, remove the antigen, get the patient away, get them away from the bees, scrape the stingers off with a credit card. And the first line treatment for everybody, regardless of what else we do, is the epinephrine IM. Studies have shown that injecting it into the anterolateral thigh musculature delivers the highest serum levels the fastest. And depending on where you are in the world, EpiPens will be 0.1, 0.15, 0.5, or sorry, that's supposed to be 0.3 and 0.5 milligram doses. In the US, the standard dose is 0.3 or 0.5. And there are great YouTube videos out there for how to hack these EpiPens and get additional doses out of them. I recommend anyone who carries an EpiPen in the field be aware of how to hack the EpiPen and get additional doses. Standard sized people A 16 millimeter needle is going to be fine. If someone's obese, a 25 millimeter needle is going to be needed for them. So epinephrine manufacturer recommendations versus real life. The manufacturer recommends always storing it between 20 and 25 degrees Celsius. This isn't possible in the field. There are studies showing that exceeding this over a short duration of time does not alter it. Insulating cases can help protect it from the temperature changes in the environment, and freezing has not been shown to alter it. Expiration dates, of course, our expiration dates are hard and fast, right? Until we have a shortage, and then it's totally safe and totally okay to go beyond the expiration date. So in the UK, they're saying, 12 to 24 months after expiration is okay. In the US, it's 9 months is the standard recommendation for that. Complications from giving the epi, rare would be an arrhythmia, a stroke, an MI. Usually the complication is kiddos taking strong evasive maneuvers and they get a scrape or a laceration. Any IV administration of epi has to be monitored. I've had a colleague do this to an evasive patient, an accidental digital injection. Warm compresses, topical nitro, and if severe, you can do a local phentolamine injection. And this is just an overview from the Wilderness Medical Society injections of the different EpiPens that are available worldwide. Field protocols from Knowles and Outward Bound are that if the patient does require epinephrine, the plan is to evacuate them. If they have refractory anaphylaxis, you can repeat the epi-IM every 5 to 15 minutes. If they're hypotensive, it's good to try to give them some IV fluids and fluid resuscitate them. If the patient's on a long-term beta blocker and they are hypotensive, you could try to give glucagon to sort of counteract that. And you want to, if it's a milder reaction, you want to observe them at least an hour, depending on the severity, preferably like 6 to 8, because they can relapse. So if they require epi, make plans to medevac them and get them out of there. And this is where I am out here. So it's 900 miles air medevac to Anchorage, which is where the real hospital is. So that's a big deal if you choose to medevac someone from out here. And it's a big deal when you choose to pull someone off an expedition. It's beautiful, but it's remote. So in summary, the Wilderness Medical Society recommendations are epi, IM, and anterolateral thigh. Antihistamines, H1 and H2. For example, diphenhydramine, famotidine are kind of my favorite little buddies. But if you're worried about having to walk someone out, if you're in the field, maybe you would give something less sedating like loratadine or cetirizine. And there's Pepcid, Zantac, cimetidine, et cetera, for an H2 blocker. Inhaled beta agonists, albuterol if they're wheezing. Corticosteroids, the data is a little inconsistent on this, but we still recommend use given the potential benefit and low short-term side effects, and observation for 1 to 8 hours, depending on the severity of the reaction, and evacuating from the field if the epi is deployed. And in summary, I highly recommend if you have some time off, you get licensed in Alaska and reach out to me and I'll put you in touch with my people. And we'll try to get you out here to this amazing facility where we get to work closely with the Coast Guard, and it's super fun. And sorry, I know I talk too fast, but I just don't want us to be here for 8 hours.
No, the speed is nice. So for somebody who's a student or resident, and not Sarah, since she just presented it, just to review, what is the definition of anaphylaxis? It can be broad, it can be your own interpretation. You don't need to read like a textbook definition. But what's anaphylaxis?
I like just signs of immune response from 2 or more systems.
Oh, just for those who don't know, what do you mean by systems?
GI, respiratory, skin, cardiovascular.
Yeah, basically it has to be 2 or more body systems. And it doesn't always have to be respiratory or airway. Let's say you got belly pain and hives, or you got nausea, vomiting, and facial swelling. It can be multiple things. And epi is drastically underutilized because people think only give epi if the lips or the tongue are swollen. I see it with, I don't mean to say anything bad about coworkers, but I've seen it even like assuming care and a sign out, and the prior person's like, hey, this, I didn't give epi because it's not anaphylaxis. And I walk in, I'm like, yeah, that's anaphylaxis. Give him epi. Let's say you're pre-hospital in an ambulance. You are a EMTP, you're a paramedic. If you're from outside the country, I don't know the different designations, but patient's tachycardic 110, anaphylactic. Would you give the epi? Sinus tac.
Oh, yeah.
Thank you. I had a patient brought in by, it was paramedics. It was not BLS. They were credentialed and under medical director followed guidelines to give epi, but they did not because it was sinus tac to 110, and they were worried about giving epi to somebody to sinus tac. They're probably sinus tac because they're anaphylactic. So you know what the weird thing was, their tachycardia improved after epi. So sinus tac is not a contraindication to epi. Again, I think it's underutilized. Anybody know the percentage risk of a relapse or a refractory anaphylaxis after the first dose of IM epi? Oh, I see a message. Let me see. Low. Yeah. It's basically less than 15 to 20%. It's more like 12 to 15, but it's enough that, hey, I don't want to have to deal with it. I'm on pre-hospital austere environment. If you were just a bystander, you're on your own hike, you come across somebody who has their own EpiPen, is anaphylactic, and you administer their own EpiPen to them, and then they're like, hey, I'm feel fine. I'm not going to the hospital. I don't want to. I did my epi. I don't have any more, but I feel good. What would you do?
Because I definitely don't have a mountain of anaphylaxis drugs in my bag. Ask them if they have any Benadryl.
No, right. See what they got. Kind of what I meant was, let's say a patient's refusing to go to definitive care. They feel their symptoms have resolved after one administered epidose.
Probably monitor them, stay with them for a little bit and monitor them.
Well, you can go hike with them, follow them. If you tell them your training, your credentials, your experience, they'll probably listen to you. But again, when you're on trail side, you don't really have, unless you're like the medical director of the park the person's in, which would be probably a little rare. All you can do is like give your advice. Be like, hey, it's my recommendation that you go seek immediate medical care. There's a chance this rebounds. Can't force you in anything. It's still free country. But just remember that pre-hospital, outside hospital care is a bit different, as opposed to like in the hospital, you're like, nope, you're getting epi. Like you're staying. They can still leave. I mean, even if they're in the hospital, you can't force them as long as they're of sound medical decision-making capacity mind. But anyway, there's stuff to think about giving care outside the hospital setting. Any other questions about like broad anaphylactic care, kind of following on the guidelines that she presented? And Vish, I sure can't think of a contraindication to epi and anaphylaxis. It's kind of like bad pit viper bite. Like they might have an allergy to crofab. Just give them epi and give them the crofab. There's not many things that were like life or limb threatening situations when you're like, I'm not gonna do it. Thanks, Danny. Yeah, I usually go with like 10 to 20 or so, but that's a pretty broad range. 0.4 to 23%.
The important thing about the biphasic is, I mean, it can happen anywhere from minutes to hours. I think up to 7 to 10 days. So, there's always that concern about, well, how long do you want to observe someone in the emergency department for, especially after you give epinephrine? I think a lot of providers have settled anywhere from, I'd say like 3 hours plus or minus one, because you're just, you're not going to admit somebody for observation because it could happen 3 days from now, and that's not reasonable.
I've seen most of my typical work of practice is like 4 hours post administration of epi that I want to watch them. I've seen people keep them for 6. I've seen people keep them for 3. It's everybody's got a different threshold. And then I've seen patients just want to leave. I'm like, well, I don't recommend it. Then you just give them good like follow-up care. Anytime I give somebody epi, I make sure they walk out of here, or just allergic reaction, and I'm not giving them epi. I make sure they get prescription for some manner of epinephrine auto injector. If they're medical or just like, I don't want to say intelligent because that it could be different types, but there is cheaper options than like the EpiPen, which is a brand name. If you're medical and you're doing pre-hospital stuff, the vials with the syringe and the kit are fantastic because you can give multiple doses from the vial, but that's not something most people know how to use, is pull up medicine using a syringe and needle from a vial. Ashley, that is a very good question. Sarah, did it mention it in the guidelines? Okay. Thank you.
Yes, the guidelines are like in the UK it says you can use it up to like 2 years after its expiration date. The US is more like they would say 9 months, and it's certainly like up to the manufacturer. And they recommend if you are going to have it in the field, try to have it in an insulated carry case. They make insulated carrying cases, but they did studies with short-term exposure to heat and it did not inactivate it.
And Danny, I saw your message about somebody saying they were allergic to epi. I was like, oh, shoot, I don't know what we're gonna do about you, man.
Yeah, I'm ignoring that if they need it, and I'm sorry.
So I didn't believe a patient once when they said they were allergic to Solumedrol. I was like, come on, what are you talking about? And I gave them Sedumedrol and they were allergic to it. Does anybody know why you can be, why would somebody be allergic to like something like a Solumedrol?
Preservative.
Yep. The preservative agent in the liquid steroid, they can be allergic to it. That's
about epi
crazy.
as well.
Sorry?
I heard the same about epi as well. It has a preservative which can cause anaphylaxis. Maybe that.
Was it epi from like a bag of epi for a drip, or was it epi from a EpiPen or auto injector? I'm just curious.
Oh no, from the vial.
Huh. Well, that's frustrating. I hope I never come into that situation. I've also seen a patient be listed allergy to Benadryl, and this was after I had a patient with a reaction to Solumedrol, so I was more understanding of it. But you can be allergic to the fixative agent that makes the Benadryl tablet. So that was interesting. I'm not sure about liquid Benadryl.
There was also one about albuterol and ipratropium bromide, because they used to use soybean oil as the fixer. And if you have a peanut allergy, you can have a soybean allergy. Some similarity. So
that was the anti-clumping agent in the metered dose inhalers, and they quit using that in the 90s. But it was the metered dose inhalers of Atrovent.
Yeah.
Right.
So I think another thing, and I think Sarah mentioned it, I think it was in the guidelines, was you don't have to have had a prior severe allergic response or anaphylaxis to have anaphylaxis. So there's case reports of people that have like, I didn't know, I've been stung by bees and only had like a tiny little welt. I've never had a problem. And then bam, full blown anaphylactic response to a sting. So it's always great if you're in a group to just have somebody with at least one EpiPen in your group, because you never know. And I think the guidelines we're talking about, like, I think it was like the page 1 or 2 about more and more we're seeing anaphylaxis in people with no prior exposure or known exposure. After that, Danny, can you? Well, we got two Dannys. Levia, could you talk about the Kunis syndrome case?
Yeah, let me pull that up. Share my screen.
I think it's kind of the most fascinating aspect of anaphylaxis, actually.
So there was a I realized this was actually just published this year, which is great. Kind of brand new reporting of 2 cases of Kunis syndrome. And so just talking a little bit about the background for people that may not be familiar with what this syndrome is. It's actually a subvariant of vasospastic angina. Vasospastic angina is also what we would call like Prinzmetal angina. And then medical students, you guys, you'll remember that this is more common in night, in female patients, especially undergoing like a significant stressor, and that these type of vasospasms are categorized as dynamic in that they can come and go, but they are high-grade obstructions, and high-grade meaning it causes such a significant degree of obstruction that you may actually see, for example, ST segment changes on EKG that mimic, for example, like an ST segment elevation myocardial infarction. They can occur without a state of increased myocardial demand. So simply stating that it can occur in patients that are not exerting themselves, or for example, like tachycardic from sepsis. They can also occur in normal or diseased vessels. And so that prototypical question that you might see is the middle-aged female has a stressor, comes in with like a STEMI on the EKG, and then when she goes to cath lab, her PCI shows completely normal vessels. Kunis syndrome itself is defined as an acute coronary syndrome. Let me see if I can, there we go. Acute coronary syndrome that will present with symptoms mimicking that ACS type picture, including chest pain, shortness of breath. And this is due to the reduced blood flow of specific arteries to the heart caused by an allergic reaction or a strong immune reaction to a drug or other substance. It was attributed to a Greek cardiologist in which he published in 1991 a reported case of possible role of an allergy in the case of a coronary artery spasm. And later on, he did 10 years later, he did a review on and kind of overview of the disease that is his eponym. The pathophysiology behind Kunis syndrome and this allergen-mediated body response causing coronary dysfunction is due to the degranulation of mast cells that typically occurs when the body is exposed to an allergen. This leads to the histamine and arachidonic acid release and cascade, which causes subsequent release of things like leukotrienes, thromboxane, prostaglandins, tryptase, and chymase. The release of these different substances causes vasoconstriction of the arteries, which can further lead to things like plaque rupture and platelet aggregation. A lot of this being very similar to the chronic development of coronary artery disease or vascular disease in general. Different triggers have been found for Kunis syndrome. Quite simply, things like drugs, foods, environmental factors. When you dig into kind of some of the specific things that have been talked about in case report and case series, there's been obviously Hymenoptera involvement, snake bites, mushrooms. There was a case in a pediatric patient that they developed it after I think months into desensitization injections being done by their immunologist. NSAIDs, a bunch of drugs, even contrast dye. COVID-19 more recently, there's been, I think, a few case reports on it specifically as being a positive causative factor in the development of these type of this presentation in patients. In general, the most common cause is drugs, and they lead to a type 1 type syndrome, which I'll break down the types in 1 second. And the incidence is approximately 1% among patients hospitalized for allergic reactions in the US. There are 3 types. Type 1 is a vasospastic allergic angina. These are in patients with no obstructive disease, and it may or may not progress to full-blown myocardial infarction, which would be the damage of the myocardium due to hypoxia or ischemic state. So you may or may not, in these patients, you don't typically see chemical marker elevation, but you can. But I think the more specific thing is that these people's coronaries are non-diseased. Type 2 is going to be an allergic mediated myocardial infarction. These are typically going to be in patients that do have underlying cardiovascular disease or coronary artery disease. And the inflammatory mediator release causes spasm and plaque erosion and rupture that actually lead to the full-blown myocardial infarction with significant, for example, thrombotic occlusion seen once these patients are taken for PCI or coronary intervention. And then type 3 is stent thrombosis. So these are in patients that already have a stent in place, and this immune cascade that is released once the body is exposed to the allergen does cause thrombosis of the already in situ stent. The pathophysiology of bee venom specifically is kind of broken down into the different things that make up its toxin or venom called apitoxin. They have neurotoxic, allergic, and cardiovascular and renal effects. It has both vasoconstricting and vasodilating properties, and some of the properties that it has may actually lead to reductions in heart rates and arterial pressures, which is thought to be due to this Bezel-Jarisch reflex that exists. I've personally seen this reflex, and I had a young female that was hemorrhaging quite literally to death from retained products of conception. And I actually saw her become bradycardic. And I knew that once that started to occur, that this was beyond life-threatening. This was somebody that's about to have a cardiac arrest. Some of the components that make it, some other specific components are like melidin, which is a complex mixture of proteins that can cause catecholamine release, metalloproteases that can cause spasms and plaque destabilizations of the coronaries, and an apomin, which can actually have a more specific effect on the calcium channels, leading to bradycardia with respect to the heart beat. And so the two cases that they discuss, the first case is an elderly male who presented with a rash, urticarial rash and itching after multiple bee stings. He did have a history of cabbage status post and also status post cabbage. And he was on some chronic medications, ramipril, Plavix, atorvastatin, in addition to acetylsalicylic acid. He was treated with steroids, Benadryl, and an H2 blocker when he came in initially and had improvement in symptoms. But about 1 hour later, he started to develop chest pain with radiation into the left arm. He was transferred to another hospital, I imagine a more tertiary type care or larger center, where they noted that the only allergy type response that was still present was just hyperemia. His vital signs were normal, and they did an EKG and found it to be this specifically. You can see that he has some diffuse ST depressions in the aneuroseptal leads, elevation in AVR, also depression in leads 2, which for me is kind of concerning for a left-sided or posterior infarct. His troponin was significantly elevated. This is a high sensitivity troponin, and so was his CKMB. And so he was taken for acute intervention, PCI, and they saw that he had a thrombus in his bypass graft. And so this was actually a diagnosis of type 2 because he did not have a stent previously in place. He just had a bypass graft that had a significant stenosis that had become completely occluded. Case number 2 dealt with a middle-aged female with a history of asthma and hypertension. No other allergies with respect to her propensity to have kind of ectopy with the history of asthma. But she presented with chest pain and with radiation to the left arm, dizziness and pre-syncope after multiple bee stings. Her vital signs, the only abnormality was bradycardia with unremarkable blood pressure. She was also noted to have widespread hyperemia with respect to the dermatologic findings of an allergy response, and she was given steroids and Benadryl. Her EKG shows a second-degree type 2 Mobitz block, which you can see on the bottom strip, quite frankly, with the PQRST complex followed by what appears to be another P complex, missing its QRS-NT ventricular response. And so you can see that with the type 2, second-degree type 2, she has a conductive beat, non-conductive beat, conductive beat, non-conductive beat. And so although her ventricular rate is 42, her intrinsic rate should ideally be double, 84. Her troponin, high sensitivity troponin was elevated at 941, but the CKMB was not. And so she was also, because of her troponin elevation with significant new onset and symptomatic bradycardia, was taken for PCI, but that was actually unremarkable with no occlusive disease found. And approximately 24 hours later, she had a permanent implanted pacemaker placed for this persistent symptomatic bradycardia. And so this is a clear example of type 1 Kunis syndrome, which is Kunis syndrome without any underlying coronary disease. And so just a quick little recap: type 1 is with patients without obstructive disease, type 2 are those with, and then type 3 are those with previously placed stent that becomes obstructed due to this immune cascade. So, okay. Anybody have any questions?
Could you please put that slide back up, the last one?
Sure. Sure.
I might have missed this, but how common is this actually, Kunis syndrome?
Well, they said it was 1% of patients admitted with a chief diagnosis of allergic reaction. So, I mean, you have to think of how many patients present to the ED with a chief complaint of allergic reaction, and then subsequently, how many do we admit? 1% of the ones admitted, I'd say it's pretty rare. Typing into PubMed Kunis syndrome brings up about 600 articles, with the majority written in the past, I don't know, well, has to be 20 years because it wasn't really given a name until 1991. But it seems to be the majority are just case reports, some reviews on kind of the underlying pathophysiology. So I'd say it's significantly rare.
Thank you.
I'd almost be curious about the number of, I don't want to say missed cases, but just never determined that a patient had this because they came in with shortness of breath or chest pain. You're like, it's because you're having anaphylaxis.
Yeah.
And you don't do an EKG or you don't do troponin or something. So I'm curious the overall actual incidence. Yeah, that occurred to me too when I was reading. I was like, well, people come in anaphylactic, they're uncomfortable, we treat them, they get better. And, I don't necessarily do adjunct testing, especially if they're kind of young and otherwise healthy. And as long as they're improving, then we treat it as anaphylaxis with improvement and they go home. So I wonder if it's actually a little bit higher. Yeah, I just thought this was kind of a cool topic. Ashley, is that what's apitherapy? What are you referring to there?
Yeah, so it's like a new alternative medication or therapy that people are using bee stingers as almost like acupuncture points. I know that there have been a lot of benefits for Lyme disease, people with really latent Lyme disease. But I'm not sure how much venom is being used or anything like that.
I'm just Googling it real quick because I've never heard of it before. I have to look into it.
Yeah, I guess it says it also includes like honey or pollen or royal jelly in addition to the venom.
It kind of sounds like a way of, quote, naturally desensitizing somebody.
Yeah.
With the desensitization shot injections from an allergist. Yeah, I'll read about it. That's I've never heard of it before. Oh, Sarah, do you just copy that? Yeah. I had the desensitization shots when I was little. It sure got me unafraid of needles. You get 2 shots a week for 5 years. You're like, I don't care. Just give me another shot. I just bring it on. It worked. My allergies sure got better. Any questions about Kunis syndrome or for Danny about that case? Vish, what do you think the Prince Metals was caused by?
I was thinking it was probably his anxiety because he came in for shortness of breath he was setting okay. He was slightly hypertensive, but everything else was normal. I just ran a 12 lead and I saw elevations. So I stopped and I asked him, I said, are you having any chest pain? Are you feeling any discomfort? He said, my chest pain is coming and going. So I asked him, is it radiating? I mean, I did the whole exam and he's like, nope, it's just coming and going. And so I gave him nitro. He was allergic to aspirin. So I gave him 3 of nitro as we went along, did a repeat EKG. It still showed elevation. By the time we got to the ED, which was about 15 minutes out, he had a normal sinus.
Ashley, I
So-
don't think of. Oh, sorry to cut you off. Go ahead. Keep going.
Yeah, so I mean, it just that's the only thing which showed up, and I would have liked to do a troponin, but we don't have that on the truck. So yeah, because I felt that it could have also been COVID causing some minor inflammatory clots or something like that, an inflammatory response that's causing some coagulopathy, which is because he did have hypertension, so and chronic hypertension, so it could have just been something that might have been causing some kind of thing. Cardiac, I'm not sure. I didn't follow up on that patient.
It's hard to follow up on patients. Like, in theory, it sounds easy, just like, hey, I'll remember that person. But you see like 20 something patients a day in the hospital. I'm like, oh shoot, they're gone. I don't know. I'll
Yeah,
see
for
when the
us-
resident writes the note tomorrow.
Yeah, for us it's even worse because we have different hospitals where we drop patients off, and then you're running around figuring out if you get back to the same hospital on the same day, and then you can maybe ask the charge nurse what happened, or the attending as to what's going on. But yeah, otherwise it's just okay, bye.
Specifically for Prince metals, usually with Prince metals, the ones I see, they're like convincing STEMI appearing EKGs, and I just get cardiology down as whether you call it a code STEMI, a heart alert, or whatever your system calls it, and then they can help me determine that because I see usually pretty convincing changes. And then for epi, I'm assuming you're referring to Prince metals from Kuna syndrome or related to Kuna syndrome. That one's tough because you're going to be wanting epi for the anaphylaxis, but increasing the myocardial demand with epi is not great for STEMIs. So that's going to be a close discussion with cardiology. You'll have them with it. Like I would want them with me or on the phone. Any other experience otherwise?
Oh, and I guess I should just clarify, I think I misspoke when I was, the second case with the female, she had those widespread ST depressions. So that would be more consistent with like subendocardial ischemia. So she was having such high grade occlusions that at least part of the myocardium wasn't getting oxygen. And so her troponin was somewhat elevated, but she had no coronary disease. So it wasn't, it's not like a STEMI or a posterior STEMI, which I misstated.
All right, we have 2 more articles basically, and then I downloaded YouTube videos about extracting additional doses of epinephrine from auto-injectors, and one of the articles is about that. So let's go through that article and then we can do some videos about it, because you can talk about cutting it open, but the video is a lot easier to comprehend. Is it Daniel? Are you presenting the article on the auto-injectors?
Yep, that's me.
Take it over.
Okay. Please chime in, pipe up if you can't hear or see my presentation, but I'm going to go ahead and get started. So I'm going to be talking about retrieving additional doses of epinephrine from auto injectors. My disclaimer up front is that I have never done this, and I'm going to try to go over these slides expeditiously because I agree the real meat here is actually seeing it being performed in a video.
We're watching your camera, not your slides.
Huh. Thank you for saying something.
There we go.
Yep, I see it.
Cool. Okay. Thank you. But you could hear everything I just said, hopefully.
Yeah, we're good. We heard it.
So yeah, this article is not a research study. It's just some expert opinion describing this improvisation technique. And the senior author or the lead author is a well-known name in wilderness medicine education. And then some of the other names are some of the other folks in wilderness medicine education who developed these techniques. So their purpose is to describe the techniques for obtaining additional doses from epinephrine autoinjectors that have already been used for that first initial intramuscular dose. So the premise here is that almost all the autoinjectors that are commercially available, for unclear reasons, have more than the prescribed dose in them. It's just a matter of accessing it. And the authors tried to reach the manufacturers for comment, and they just basically said that it makes the delivery system more stable by having that additional epinephrine in the injector. As far as actual real world experience that's been reported, they did mention in the article that the Wilderness Medicine Outfitters, I think is called, some of the folks that came up with one of these techniques, they did report a case report of a physician reversing a biphasic reaction in an austere environment by using this technique. And then another case was reported again in 2012 where this ended up being life-saving. So we've already alluded to a lot of this. So basically this is a necessary technique to master because anaphylaxis may be biphasic or protracted. And like we also talked about, there's a wide discrepancy in what's reported as far as how often this happens. And the authors, to kind of say that this problem is important, they kind of went with the higher range and saying that this happens as many as a third of all cases. And so the reason why this may be helpful is that a lot of people don't carry more than 1 or 2 EpiPens. And so it may be, and especially in an austere environment, it may be impractical. And if you have a large group, to carry enough EpiPens or autoinjectors to handle a biphasic or protracted reaction before you're able to get to definitive care. So autoinjector is the generic term for all of these commercially available devices, the most common one being the EpiPen. And they changed their design in 2010. So that's going to be one of the things we're going to talk about, is there's a little bit of a difference in how you approach this technique, depending on which device you have. And you would think that all of them in the market now that it's been 12 years, would be the new design. However, they did mention that epinephrine does have the possibility of being effective even past its shelf life. And if you're in some austere environment where you just happen to find a stash, I guess it's conceivable that you could still find one of the old designs. And then the same company makes the dose for children, so the half dose, the EpiPen Junior. Then there's the twin inject, which is actually the only one they talked about that is designed to be able to deliver a second dose. Then there's the Adrenaclick, the Greenstone, and then not available in the US that I know of, but commonly used in Europe is the Anapen. These are all ones they talked about in this article, but I'll talk in the end. These are not the only ones that are now out there. This article is in 2013, so it's conceivable that more devices may become available in the market, and we'll have to, as providers in the pre-hospital environment, be familiar with new techniques for new devices. So the premise relies on the fact that you have some sort of device to assist you in opening these auto injectors. So the ideal situation is you would have some sort of multi-tool like a Leatherman, where you'd be able to leverage both a cutting instrument, the knife end, and also the pliers end. But some of these techniques described, you can just use a knife without having a pliers. I'm just going to kind of summarize overall, because again, the video is going to do this a lot better justice. But there's kind of 2 approaches created by 2 different institutions. One kind of relies more on just cutting through, and the other one, you do a little bit of cutting to create some space for you to be able to get your pliers in there, but ultimately you're using the pliers a little bit more. So the post 2010 EpiPen has a more ovoid shape that allows it to be recognizable based on that shape. And so you're basically going after the end that's opposite the needle. And as you can see in the picture, you're wedging that knife in there and making some cuts and kind of bending the plastic back so that you can get a grasp on the plastic in there with your pliers and basically pull it off and remove the syringe inside. And the Rowan State method is basically to just, if you imagine like a pencil, just basically cutting through it. Then the pre-2010 EpiPen you're just taking a pliers and wiggling one of the ends off, or again, cutting through it if you don't have the pliers. The twin inject is the one that I talked about that is designed to be able to be opened up to access a second dose without having to jerry rig it. So you unscrew, I believe it's the needle end of it, and you just have to remove a clip, and then it'll be all set up to deliver a second dose. And then the Adrenaclick or the Greenstone models, I think basically they describe it as using a pliers to pull off the cap that is on the needle end of the device. So once you've actually broken through the housing with your knife or your pliers, then you have access to what you'll see here is the syringe with the medication inside and the needle. And it's designed to deliver the appropriate dose, which is 0.3 milligrams of epinephrine. And so there's a stopper on the syringe so that it isn't administering an overdose. And so for you to be able to give more, basically they're describing you invert it and then draw air in and then turn it back over so that gravity puts all the liquid towards the needle delivery end. And then when you depress the syringe up to the stopper again, you'll lose a little bit because air is compressible, but it will deliver more medication. And so it's out of the housing, so it doesn't have the whole auto injector just kind of slam to the hip thing, but you're basically going to insert the needle in the anterior lateral thigh and put the needle in and deliver that dose. So you're going to have an exposed needle. Obviously, as it's marketed, the device has a bunch of safety features. The needle's never exposed in the new 2010 post 2010 EpiPen. You put it into the hip, into the thigh, and then when you pull it out, it protects the needle automatically. But here you have an exposed needle, and so that's certainly a consideration with these techniques, is that you're going to have a needle that's already been in someone's body, so there's kind of bloodborne pathogen thoughts there, and then that person's life who's having the anaphylactic reaction, their life is kind of in your hand. So you have, if ostensibly this is all the epinephrine that's available to them, you want to make sure that you're handling it safely and not losing whatever remaining doses are there. And so I just described the way that they think is most effective to deliver that, the additional doses. Other people have described, you could wiggle the end of the syringe off. You could try to draw it up into another syringe to deliver it if you happen to have one, but doing all those extra manipulations could risk you losing this precious life-saving medication. So this is kind of what they landed on as kind of the most effective way to deliver it. There's no markings on the vial, as you would see on a syringe, to know how much you're delivering. You're just relying on the fact that the stopper is going to deliver that appropriate amount of medication. Safety is an important thing. I've heard a lot of people talk about this is kind of controversial because people are going to be doing this and they're going to hurt themselves. And I guess I haven't said this yet. You should only be doing this on an auto injector that has already delivered an initial dose, because there is a spring in there, a very powerful spring that's all wound up. And once you deliver that initial dose, it's going to unwind to some extent, and there's going to be a whole lot less potential energy. And so if you're cutting into unfired auto injectors, you're asking for potential injury. And so after it's been fired, a lot less chance for injury because it's significantly unloaded. They say you should be wearing eye protection unless you're doing an outdoor activity where you otherwise have eye protection. I think that's a little bit unrealistic, but I guess if you have sunglasses or whatever, that would be the safest thing to do. And they emphasize using a fixed blade, or at least a blade that locks, because if you're using a pen knife that doesn't lock, you could cut yourself as it folds back on itself. Use a hard, stable surface so you're not like slipping off and cutting yourself. Don't point the needle or the spring towards anybody else. And I already talked about it, should have already discharged. And then you're going to have an open needle, so use precautions with your sharps. And so the manufacturers are concerned about liability, and they wrote a response as a letter to the editors, basically saying, we don't condone any of this. FDA didn't approve this. This is not how it was designed. Didn't explicitly say horrible things are going to happen. I think their lawyer said you need to say that we don't endorse this. But that being said, that's not the way it's designed to be used. Obviously, they're only labeled for single use. But of course, there are risks with it. But you're doing this to save someone's life, so who cares if it's risky? And then another key point is if you have a large group of people who are going to take in the wilderness and think statistically I should have 5, auto injectors, but I could reuse each one like 3 times. Like you obviously shouldn't plan that way. You should plan to have an appropriate number of auto injectors. This is like a stopgap measure to save someone's life. And then the authors advocate for practicing this technique because obviously if someone's dying in front of you, you want to be, you want to know what you're doing and not be kind of figuring out on the fly and potentially lose the dose if you mess something up. This kind of reminded me as an emergency medicine resident of we talk a lot about making push dose epi until you actually like fumble with the crash cart epi and how to get it and draw it up. It's not ideal. You would have done it before you need to do it in prime time. So that's why you practice. But then again, if everyone's practicing with it for a rare procedure, you run the risk of people getting injured preparing for this technique. That's the chances of them having to actually use it is pretty small. As far as kind of analyzing this article a little bit more, the limitations are that they only talked about 2 case reports. So if there are actually adverse effects of doing it this way, the sample size is pretty small. We don't necessarily, it's not powered, so to speak, to find any potential risks. Again, the manufacturer's a little bit biased, and this is obviously a possible way to save someone's life, but they're concerned about liability. And yeah, I talked about you want to be familiar with it. And then as new devices come on the market that are not described in this paper, we're gonna need to figure out how to access those. And so there was actually other articles in the Wilderness Environmental Medicine, how do you access the AVIQ, I think, written by Robinson and Leroux in 2016. And I think there was another article about the Adrenaclick. I haven't read any articles, but I know another device is the SimJeppy. And then to bring it all home back to Sarah covering the WMS guidelines, they even talk about this technique. So they say for austere or disaster conditions, the off-label techniques for disassembling an EAI after IM administration to obtain another epinephrine dose are available and should be considered an inherently risky but potentially life-saving measure when no other source is available. So I think that sums it up pretty nicely. And those are pretty much all the articles that I could find that have anything to do with this. If Justin has access to the videos, I think it'd be great if you can bring them up. Otherwise, they are on, if you access the article from the Wilderness Environmental Medicine website, they do have 3 videos in the supplemental content as well. But obviously YouTube serves that purpose too.
Dan, I'm gonna take over the share screen. And
Perfect.
It's somewhere. It's here. All right, can you see this YouTube page? Okay, so as a disclaimer, 2 of these 3 videos were made by my fellowship group because there's not many out there. And then the 3rd is by the producer of Adrenaclick, I believe. So that's first one's the Adrenaclick. Since we just talked about the EpiPen, let's just do that real quick. Oh.
The Teva epinephrine autoinjector can be opened with a common multi-tool or using a knife and screwdriver. Proceed to dispense the initial dose of epinephrine as instructed by the pen manufacturer. 1, remove the blue safety cap. 2, unscrew the yellow end cap. And 3, inject the initial dose of epinephrine into a large muscle. Next, we will disassemble the epinephrine autoinjector to retrieve additional doses. The outer clear plastic shell of the autoinjector is made up of multiple parts. You can locate the seam where there is no label. Using a knife, you'll need to score the label along this seam so that it can be fully separated. Seam will follow a diagonal path on the sides and a horizontal path on the flat section of the autoinjector. Next, we need to peel the label on both of the diagonal sides to reveal 2 plastic clips. We'll now need a tool to pry up on these clips. A can opener shown here or a flathead screwdriver work well. Do be cautious working with the auto injector. There is a dirty needle under the orange cap, although it should be locked in place. You will need to work the pry tool under the plastic shell that is holding the clip in place. This may require some force. Once securely under the plastic shell, apply downward pressure with the handle of the tool, prying upwards to break the plastic shell. Repeat this process on the other side. The end of the clear plastic outer shell should now slide off the end. If you're having difficulty, ensure that both clips are free and that the label has been fully cut. There are two smaller white plastic clips further down the auto injector below the two clips that were just destroyed. You will have to peel or scrape off the label in order to locate these. They will be square in shape and recessed into the body of the auto injector. These two clips hold the remainder of the outer shell in place. These clips cannot be pushed in as they are tightly fitted around the inner syringe. Instead, you'll have to use a knife to drill out the white plastic clips that are set in the outer plastic shell. The outer shell is made of a very thick and hard plastic that is very difficult to cut through. However, the white clips that are being drilled out are very soft plastic. Continue drilling out the white plastic clip until it is well below the level of the outer shell. Repeat this process for the clip on the other side. This will likely be the most time-consuming step in this process. Confirm that both white clips are sufficiently destroyed. Once both clips have been destroyed, the orange core containing the syringe should slide out of the remaining outer plastic shell. Proceed with caution as there is an uncapped dirty needle under the tip of the orange sheath, which we are now going to remove. To remove the orange sheath, pry apart the two arms, which will allow it to slide off, exposing the needle. There are about 1.25 milliliters of epinephrine remaining in the tube. And now is a good time to mark these additional doses by first bisecting the remaining fluid and then cutting it into quarters. This can be marked with a pen or even scoring the outsides of the syringe. This will give you 4 doses of approximately 0.3 milliliters of epinephrine. The next step is to remove the white end shroud and spring. This cap is spring loaded with an exposed sharp on the other end. You will need to proceed with caution. The best way is to have a second person firmly hold the syringe body with the needle pointing away from all persons. Pry the two white clips away from the syringe. The spring-loaded mechanism will then remove the white plastic. This is under tension and it may shoot off the end of the syringe. The plunger arm is not attached to the rubber plunger, so it cannot be drawn back or pushed further forward. You'll have to find an object with a diameter smaller than the inside of the syringe to use to expel the remaining doses. In this instance, a screwdriver is used to administer the remaining doses, but other options include a stick, stiff wire, matchstick, tent stake, or other object. You can now use the 4 remaining doses of epinephrine on the patient. Remember to avoid getting stuck with the needle and to keep the needle.
All right, so that was one brand of auto injector. As you can tell, it's not the quickest process. And that's people that know what they're doing. Granted, they're doing it for demonstration purposes, but it's not something you want to wait for somebody to be symptomatic again to start the process. So if you think you're going to need it, I would recommend just like starting on that, or maybe somebody else in your group starting on that process, like right after the first administration, because that took some time. There are 2 other videos, but I can just email them to everybody. We could sit and watch them. I think this was the longest one. Anybody feel strongly about watching more videos now versus continuing with the next case? I guess, Drew, why don't you, I think you can take over share screen. I'm going to stop share myself. Why don't you bring us home with the last one?
Yeah, I was muted. It's kind of short and sweet, 3 pages. One was intro, one was outro. Can you see it fine?
Yeah, you're good.
Cool. This is just a case report presentation about airway edema after a bee sting to the uvula, which is unique. So setup was just for statistics purposes, 62 deaths per year in the US are attributed to bee stings. And what I forgot to write here was this was set in Costa Rica, where they also attribute about 52 deaths per year just due to bee stings. A 15-year-old's going on a zip line, screaming, your mouth's open. She catches a bee in her mouth, and they say she estimates it was in for 5 seconds, and it stung her on the uvula. Go back. So within minutes, she has swelling in posterior oropharynx, dyspnea, dysphonia, drooling. So eventually she gets to their emergency medical clinic. Her vitals are relatively fine. She's 15, it's been stung in the mouth by a bee. She's going to be a little tachycardic. So currently we have no stridor, no real edema, clear lungs, no rashes, no urticaria. So right now all we have is just a local irritation. We have no systemic responses. So they noticed there's a black stinger in the back of her uvula, and so they were extracted. Unfortunately, this was a tweezers, which I understand is the less than optimal means of extracting a stinger from a uvula. And she starts to report tightness of the throat, swelling, shortness of breath. So they give her epinephrine. You can see the progression of the initial on the left, 2 hours after epi on the right, or in the middle. And then on the far right, we have 12 hours after resolution, which I like to find interesting is just the tongue size difference and the local swelling, especially lips immediately versus 12 hours later. That was just me. So what they ended up doing for this girl is they gave her 10 milligrams dexamethasone IV, chlorpheniramine, which antihistamine they had on tap. And as they did not have the IM formula of epi, they gave her 0.1 milligrams IV over 5 minutes. So initially, when she came in, they gave her the dexamethasone and chlorpheniramine. And then when she started to report the tightness sensation in the back of her throat, swelling, difficulty breathing, that's when they gave her the epi IV. They did not give a weight on this, but we're just going to assume normal size 15-year-old. So it's still under a pediatric dose, but it is IV, but it is slow, but it worked. So they observed her for only 2 hours, gave her prednisone and rapatidine. I'm not familiar with. I'm going to estimate it's another histamine blocker, maybe an H2. And evidently she has a full recovery.
Yeah, I just remember seeing that case, and I was just like, no way. How can you get stung on the uvula? I'm sorry, snorted. How can you get stung on the uvula? So that would just be, that sounds so horrible. Second generation H1. Oh, cool. Sorry if you're hearing a lot of wind. It is remarkably windy here in Virginia right now. If you can hear me. Yeah, that one would have made me a little nervous coming in. Personally, I would have gone like straight to the epi, and then you realize, hey, I don't have IM epi. So I'm curious if they gave like crash cart epi or what they did, where they got. I don't know what concentration of epi they used. But yeah, there's stuff you got to do when you're not at a tertiary care hospital. Even when I'm at my critical access place, if I have a STEMI, my cardiologist is, especially in whether you want to call it post-COVID or actively COVID area, can be a long time to get your patient transferred to definitive care, or if you're in the Aleutian Islands. What is this? I'm just reading Matt's. Oh, geez. Yep. I've never had to go beyond epinephrine drip. I haven't had to go down that route that far before. Yeah, that's a really bad one. So that's pretty much it for the actual like article content I had for this month. I figured it would be cool to watch the other videos just because I sure have never cracked one open personally. I can tell you the reason that my fellowship made 2 videos like that is in a whitewater rafting trip in the New River Gorge. I think it was last spring. I wasn't on this trip. One of the people on the raft who had never had an allergy to bees before went full anaphylactic to a bee sting, and it was bee, not wasp or hornet. They took out the stinger. Luckily, somebody had an EpiPen, and it was EpiPen. It was brand EpiPen, and they had to give a second dose. So one person or 2 people split off because they were at a pullout. They were actually having lunch at a pullout. They ran off to the nearest CVS, which is still a drive away. Plus, they got like, please give me EpiPen. I need it. I don't have a script. And then somebody sat there and cracked it open because they saw a video like this and they gave a second dose. So that's why a fellowship now is focused on doing videos like this. So I'm just reading everybody's posts real quick. All the bears. Yeah, and I think something mentioned earlier about like causing injuries with auto injectors. The main key is you grip it. I don't have a pen with me, but phone will work. You grip it like this. You don't grip it like this. So, while you're stabbing somebody. Yeah. So I've had a patient, I don't know how they did this. They had the needle go through their palm. I'm really curious why they would hold an EpiPen like this.
Actually, there was a funny one. There's some Harrison Ford movie where for realism, they just gave him a deactivated but still clickable real EpiPen. And he did that exact palm grip technique. And there's a spring that recoils through the hole in the back where the safety cap is. And it stabbed him in the palm.
Yeah, I had a patient. She took a picture of it dangling from her palm when she came in. She's like, "There's Epi in my hand." I was like, "Nah, you'll be fine."
Like the needle end or the not needle end?
We took an X-ray to make sure it was out, but the needle came out. And then one of our fellows from, I think it was 2 years ago, going on 3, during an AWLS course, somehow a live but expired EpiPen ended up in our jumbled up pile of trainers. And he got injected with Epi. It was a correct administration. He's like, that hurt more than it should have. And then they like pulled his pants up or pulled his pants down. He's like, oh gosh, I actually got hit with live Epi. He's fine. He's a quite extroverted, hyperactive guy anyway, so we didn't really notice much change. Not that we would anyway. That's not how it affects you. If anybody wants to stay on, I'll show the next 2 videos. If everybody just logs out, I'll turn it off. I just think it's a good way to see these videos in that way. If somebody watches it recorded, they'll see all of them in one place. So I'm just going to go back to sharing my screen. And so this is called the AviQ for anybody who's still here. I've never personally used this one.
Removal of additional epi from the AviQ.
Let's try a 1.5 speed.
First, remove the auto injector from the casing.
If you are ready to use, pull off red safety guard. If not ready to use, to inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 4, 3, 2, 1. Injection complete. Seek emergency medical attention.
Next, remove the label from the device. We recommend the use of gloves and eye protection during this project. Using a multi-tool with pliers and a screwdriver, will be helpful in the disassembling of the ABQ. Use the screwdriver to pry off the back battery casing.
Your physician or proper disposal with a prescription refill. This device has been used and should be taken to your physician for proper disposal with a prescription refill.
This step is optional. Using pliers or a similar tool, gently remove the end cap from the remainder of the device. Once the end cap is free, get CO2 cartridge from the device. Then locate the CO2 needle on the right side of the picture and remove it from the device.
The vial containing epinephrine is located in the center of the device. Using a screwdriver, the plastic sealant can easily be removed. Use caution in this step, as an exposed needle will be revealed. To fully remove the vial, you must flatten the hard plastic rim surrounding the enclosure. Using caution, remove the syringe by grasping the green support. There will be an exposed used needle in this step, so exercise caution.
Using the clear plunger attached to the vial, advance it until it meets the end of the glass to deliver the second dose of epinephrine. In order to deliver the third and final dose of epinephrine, grab the end plate of the IVQ and remove the CO2 cartridge. Using one of the white plastic prongs on the end plate, you can compress the plunger through the remainder of the vial, being careful to spread the green plastic supports so that the plunger can be advanced until the final dose is delivered. This is not the manufacturer's intended use of this device.
So pretty different, although basically the end goal is to get the core needle and vial containing portion out. The cool thing about this one is you just basically need pliers, and then you can use components to administer the additional doses. So the Tiva brand can give, what was it, 5 total doses? The initial dose plus 4 additional. And then this one you can give 2 additional, so 3 total. I didn't even hear about the AVQ until a year, maybe 2 ago. So that one's still somewhat new to me. Has anybody used one of these? Sorry?
No.
Yeah, it's just not one that I've seen much about. All right, this one's quick, and I've cranked it up to 1.5 speed.
This video will describe 2 techniques that can be utilized to obtain additional doses of epinephrine from the Adrenaclick and Adrenaclick style generic epinephrine autoinjectors. Throughout the video, I will refer to the Adrenaclick autoinjector, but all techniques also apply to the generic epinephrine autoinjector. Warning, the following method is not approved by the FDA or manufacturer. This is only meant to be utilized in an austere, limited resource setting in the event of life-threatening anaphylaxis refractory to a single dose of epinephrine. Both of these techniques are to be used only after giving the first dose of epinephrine. To use this injector, remove from the protective cover, remove cap 1 followed by cap 2. Push the injector into the lateral thigh to inject and hold for 10 seconds. We recommend not injecting through thick clothing as it can damage the needle and make it difficult to administer the second dose. Unlike the EpiPen autoinjector, the Adrenaclick autoinjector does not cover up the needle when it has been utilized. While attempting to disassemble the injector, be mindful of the needle. Bending or breaking the needle can prevent you from being able to provide an additional dose of epinephrine. Also, please be careful not to stab yourself. The first technique we will demonstrate uses pliers to disassemble the autoinjector. Grab a hold of the red cap with the pliers and twist off the cap. Twisting off the cap requires a considerable amount of force and is not possible to do by hand. Once the red cap has been removed, the syringe can be utilized to give additional doses of epinephrine. The inner syringe has markings to display how much drug is available. Use the ampule to draw up air and invert to give additional doses. This is required due to the specialized plunger within the autoinjector, which, unlike a normal syringe, only allows for the administration of the pre-specified single dose. The ampule has markings to ensure accurate dosing, 0.3 milliliters for adults and 0.15 milliliters for children. Be careful not to completely withdraw the plunger, as you risk losing your additional epinephrine. If you don't have pliers available, a knife can also be utilized to disassemble these autoinjectors. However, both options are available. We find using pliers to be the easier technique. To use this technique, begin by removing the wrapper to uncover the outer casing. Do not attempt to cut at the red cap or at the groove between the outer and inner housings, as you risk damaging the syringe during this process. The plastic casing used for these autoinjectors is harder than the plastic used for the EpiPen. It's preferable to use a serrated knife to do this procedure. The syringe is protected by 2 separate casings. You will need to cut through both to access it. It's recommended to cut between the syringe and spring to prevent damaging the syringe in the process. The syringe is now available to administer a second dose of epinephrine. Thank you for watching. We hope you've enjoyed this tutorial. Now get out and play.
Cool. Yeah, man, that's pretty cool. It's did you know that they made this video before?
No, I did not. I noticed that Dr. Byrne was one of the authors at the end of that intro. That was pretty cool.
So different techniques for each model. If you're going to take it with you on a like adventurous trip or going to be medical support for a trip, it's probably good to know that one, you'd probably want to have the appropriate number of doses for your team, but you'd want to know how like ins and out of every aspect of your device that you're choosing. And Vish, I did not see that Seth made one as well. I just chose the ones that I've heard of used the most, and I went with those. But yeah, YouTube search and you'll find more cool videos. As far as anaphylaxis and allergy goes, any other questions or experience you want to share, anybody? Okay, so this next month, October, is going to be on kind of infectious disease for the traveler. So sometime this week, I'm going to be meeting with an infectious disease specialist who has gone on medical support trips, has sourced medications to be used on trips across the world. So hopefully we can have somebody who's firsthand experience with that help us out next month. And it might be more of like we all learn as a group from him. Hopefully we can have some journal club content as well. It might just be a cool lecture opportunity for us. Vish, how soon? Refractory, a couple hours. Sorry, I don't want to, refractory might not be the word. Let's say refractory. Rebound will be a couple hours. Refractory, I've had to give a second dose of epi in 5 to 10 minutes. But rebound will be a couple hours, up to a couple days. Yeah. Matt, I've had to give, I think I gave 2 or 3 doses of IM epi, and then I was just like, yep, because I couldn't get the epi drip soon enough is why I gave the 3rd one. I was like, I'm not sitting around waiting on the drip, just give it right now. And somebody mentioned a dirty epi drip earlier. At night where I work at the big hospital, we don't have pharmacy. We'll soon have nighttime ER pharmacy, even at night soon. That's going to be awesome. But during the day, pharmacy comes to these. So I'm just like, please give me an epi drip, and they get it to me in a couple minutes. But at night, or if I'm at like critical access hospital, it's good. It's something good to know. Or if you're off the coast of Alaska on an island, you might need a dirty epi drip. So it's just cool stuff that talk about in cases like this. And then we've probably cursed us all to see some bad anaphylaxis soon. So hopefully we're ready for it, everybody, because if we're ER, we're all kind of probably the most superstitious specialty out there. So it's going to happen. But yeah, see you guys next month. If anybody wants to be involved with presenting, let me know. Otherwise, I'll see you in about a month. Thanks, everybody.